Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, TNFOG with AMOGS Webinar. So let us start the webinar with Saraswati Vandana. So it's my privilege to introduce trouble with the audio.
No problem.
So it's my privilege to introduce the conveners of today's webinar, Dr. Pradya Supema. Ma'am is a consultant obstetrician and gynecologist, laparoscopic surgeon and lactation consultant. Ma'am has been attached to Surya Hospitals and Gen Hospitals, Secretary of Manager Jogi, MOGS Managing Committee member. I welcome you, ma'am. And it's my privilege to introduce other convener, Dr. Madhumita Arun Karthik, ma'am. Ma'am is the consultant obstetrician from Salem, National Coordinator of Midlife Management Committee, FOXY, South Zone and TN State Coordinator, FOXY, Presidential Activities 2026, FOXY Youth Cell member.
Thank you, Sarthi.
Yeah, I welcome you, ma'am, and I hand the session to you.
Thank you, Sarthi. So, Pradanya ma'am, you'll introduce Sampath now. Can we have the CV slide, please?
Can we have Sampath ma'am CV, please? Yeah. It's an absolute honor to introduce. Yeah. Dr. Sampath Kumari ma'am. Ma'am is professor and HOD, Shri Muthukumaran Medical College. She is FOXY Vice President 2022, National Corresponding Editor of Jogi, Founder Secretary of Tamil Nadu Federation of OBGYN, immediate past president.
Thank you.
And over to you, madam.
Start the program. Yes, sir. Thank you, Pranya and Madhumita. Now we will start the program. This is the TNFOG with AMOGS Webinar. This is the third week. We had a wonderful talk on the panelists for the past 2 weeks. Now we will invite Dr. Ame and for a few words. Dr. Ame, are you there? Dr. Ame is the president of AMOGS and the joint treasurer FOXY 25-27, joint secretary.
Yeah, madam, I'm there.
Yes, and thank you, Ame. Yes, you can, few words.
Yeah. Good evening, everybody. Gives me great pleasure to be here this evening. It is raining heavily or started raining heavily in Mumbai. So from the heat, we are now enjoying the rain. It's my pleasure to collaborate with TNFOG in this partnership. I'm thankful to Dr. Amla ma'am for President TNFOG and Dr. Sampath Kumari ma'am, Secretary TNFOG. We have seen the way Dr. Sampath Kumari has dedicated herself not just to TNFOG but to FOXY, and I wish her all the best in her future endeavors so that she rises to the highest post in FOXY. I'm also very happy to see the presence of Dr. Ajay Mane, Vice President of AMOGS, Dr. Rohan Palshetkar, Secretary AMOGS, and Dr. Parag Biniwale, past chair of ICOG and a very popular and favorite AMOGSian. Also, special mention of our true privilege to have Revati Madam amongst us, past TNFOG President, and Dr. Vidya Prabhakar Ma'am, also past TNFOG President, shows that truly this gesture between AMOGS and TNFOG is blessed by the stalwarts who have founded TNFOG. Special mention of the hard work put in by Dr. Sampath Kumari, Dr. Pradnya Supe, and Dr. Madhumita, who are the conveners for this web series. And really, I appreciate the hard work that you all have put in for ideating this web series with important clinical as well as practical and important topics. Indeed, it is our privilege today to have amongst us esteemed faculty, Dr. Girija Wagh and Dr. Ramni Devi, who will be talking or moderating an important practical-based panel on the difficulties during cesarean section, and Dr. Gaurav Desai, who will be enlightening us upon the issues associated with maternal mortality and morbidity and how we can correct them and how we can prevent them. the panel is going to be having a lot of eminent faculty from Maharashtra, from Tamil Nadu and beyond. And that is the whole purpose of this web series, to collaborate, to come to a consensus and to understand how together we can learn from each other's experience and give the best to our patients. Once again, congratulations on this web series. My best wishes to Dr. Sampath Kumari, and my sincere appeal to all the delegates and fellow Amoxians, Foxians to please attend this, because it is really for the benefit of you and your patients. So wishing you a great success, and thank you very much for having me this evening.
Thank you, Dr. Ramaya. Here also we are having the heavy rain. That's the reason I thought before the signal goes, we will start the program. Thank you. So I welcome Dr. Rohan for a few
Yes.
words. It was really great to have the TNFOG and AMOGS. Yes, Rohan.
Yeah, madam. Firstly, I want to say a big thank you for collaborating with AMOGS, because as I said in our previous webinar also, we're all here to learn from each other's experiences. We all read the evidences which are there, which are accessible to all, but each person's experience is different. What also I love about the topics today is that these are topics where we require a collaborative effort to make sure that we get a good maternal and fetal outcome. And through the collaborative efforts of TNFOG and AMOGS, we should be coming out with brilliant answers for all our delegates who are there to learn. I don't want to take too much of the time because of the rains. I want to ensure that the scientific program goes on strong and safely. So I'll hand it over back to you all, and I wish the faculty and the delegates a very beautiful learning from this webinar.
Thank you, Dr. Rohan. Now we will go with the blessings from our Dr. Chief Guest Parag and Ajay Mane. Dr. Parag is the consultant in Pune, and he is the PG teacher and unit head and past chairperson of ICOG and president of Menopause Society Pune and president of Pune OBG Society 22 to 23, national website editor Foxy, and peer reviewer for Joki and chairman. He was the young talent promotion committee chairperson. Of all this, today morning only, since yesterday I was in Amravati. So I talked to Dr. Parag today morning only. Immediately he accepted that. Thank you, Dr. Parag. Please, few words. Not audible.
Sir, volume is not audible. Sir.
Not audible, sir.
Parag, not audible.
No, sir.
Not able to hear, sir. Hello? Okay, sir. Okay, sir. Ajay, okay. Ma'am, Parag sir will just check the volume and again join in a minute, ma'am. By the time I think we can have Ajay sir's blessing.
Ajay sir, yes, you can have the CV of Dr. Ajay Mane. Dr. Ajay Mane is the Vice President of AMOGS 2026-28, Vice President Foxy 2024, State Representative of AMOGS 24-26, and member of NMC and PCP&D wing of
Madam,
Government of India.
We'll skip this.
Yes, Ajay.
Yes.
Welcome,
Thank you,
Ajay.
madam. Yeah, I am actually honored to be here as a chief guest. Thank you very much. TNFOG office bearers, Dr. Amla ma'am, who is the president TNFOG, and our beloved Professor Dr. Sampath Kumari madam, who is my elder sister. She is secretary TNFOG. My AMOGS office bearers, president Dr. Ame and secretary Dr. Rohan. My elder brother Dr. Parag Biniwale, past chairperson ICOG. And guest upon us, Dr. Revati ma'am and Dr. Vidya madam, who is the TNFOG past presidents. All stalwarts gathered here, and the conveners, Sampath ma'am herself, Dr. Pradnya from our area, and Dr. Madhumita, who is actually not in midlife, but she is the national coordinator of midlife. She is too young to be there as a coordinator in that committee. Okay. And I am fortunate that I am not the panelist, because the moderator is very strict teacher, Dr. Girija. She is a very strict and say very knowledgeable person. So I am fortunate that I am not the panelist. So you are having two topics, based morbidity and mortality after PPH is a very important and day-to-day concern topic. And second is difficult scenarios in the LSCS. And the expertise respected Dr. Ramni Devi. And I know this is going to be very knowledgeable webinar. So everybody must record the webinar and hear again and again to save their life from the difficult situations. Secondly, I convey my very heartfelt best luck to Sampath Kumari ma'am for her endeavor in the FOXY, and I urge everybody to kindly vote for Sampath Kumari madam to have a great again president for our FOXY. So thank you Sampath ma'am, and thank you Madhumita for inviting me here. So best luck for your webinar, and best luck Sampath ma'am for your endeavor in the FOXY. Thank you.
Thank you so much, Dr. Ajay, with all your wishes. Thank you so much. Thank you. We'll go with the guest of honor, Dr. Revati Madam. Revati Madam is the past president of Madurai, past president of Menopause Chapter Madurai, and she was the vice president in FOXY and our past TNFOG president. Revati Madam.
Yeah. Good evening, dear friends. It is indeed a great pleasure for me to be here at the joint venture of TNFOG and AMOGS. AMOGS is always very close to my heart. The topics chosen today are really very crucial: PPH mortality and morbidity, as well as difficult scenarios in LSCS. And we are talking a lot about PPH and conducted many CMEs and workshops, hands-on training and everything. But one point we have to remember is that the response of the patient to amount of blood loss as well as the response to the uterotonics is not the same in every woman. So that also we should keep in mind. And the PPH topic they have chosen is from a different angle, whether this mortality and morbidity is a system failure or cognitive failure. And I'm very eager to hear from Dr. Gaurav what he is going to talk on it. And the second one is from the HDP lady, Dr. Girija. She is going to moderate the panel on difficult scenarios in cesarean section. I'm sure the discussion will give a lot of take-home points for the delegates. And I wish this webinar a grand success. And my humble request to each and everyone, you tell your friends also to vote for my dear Sampath Kumari to win in this FOXY president election. Thank you very much.
Thank you, madam. Thank you so much, Revati madam. We can have a different PPH talk by Dr. Gaurav. See, madam, it's entirely different. Yes. Now we have Dr. Vidya Prabhakar.
Parag has joined. Parag sir has joined. Yes, ma'am.
Yeah. Okay, good evening. It's indeed a pleasure to be invited by the TNFOG and AMOGS. So thank you, President TNFOG, Dr. Amla Devi, Dynamic Secretary, Dr. Sampath Kumari, and of course, AMOGS office bearers, Dr. Amaya and Rohan. Thank you for this honor and opportunity. It's indeed a pleasure being here this evening. Today, in fact, even in Pune, we started experiencing rain. So today happens to be a very happy day for us Puneites who are really being troubled by heat. Sampath, I must compliment you for thinking of different topics. I personally really like the topic which Gaurav is going to speak on. And of course, the panel discussion would be something which would be a great learning experience, which would be moderated by Girija with expert like Dr. Ramani Devi. My best wishes for the program, and of course, best wishes to you for your forthcoming elections. I'm sure you'll do a great job. Thank you.
Thank you, Dr. Parag. Thank you so much. Because of the Parag, we started the adolescent certificate course in ICOG. Thank you once again, Parag.
Thank you.
Okay. Dr. Vidya. Dr. Vidya Prabhakar is our past president of TNFOG, past president of Salem Society, and because of her, we had a lot of collaborations with the government to reduce our MMR. Dr. Vidya?
Ma'am is in a case, ma'am. She said in the middle she'll join as soon as she finishes.
Emergency. Okay, yes, no problem. Now we'll go with the scientific session. Once again, I welcome all the delegates and the faculties to hear the talk by Dr. Gaurav Dosai, the PPH, and the panel discussion by Dr. Girija Bag. Thanks to Dr. Parag, Dr. Ajay Mane, Dr. Revati Madam, Vidya Prabhakar, and Dr. Ameya Prandre and Rohan Palchekar. Madhumita, you can introduce
Yes,
Gaurav
ma'am.
Desai.
Yes, ma'am. Yes, ma'am. We'll have Pradanya ma'am introducing our chairpersons, ma'am. Yes.
Pragnya?
Pradanya ma'am. Yes, ma'am.
Yes. So our first chairperson for today is Dr. Suhasini Karnal. She is consultant obstetrician and gynecologist. She's UG from Chengalpattu Medical College, working as associate professor in Sri Muthukumaran Medical College. Welcome, ma'am.
Yeah, welcome.
Our next chairperson is Dr. Shravani Chitra. She's currently working as associate professor at Sri Muthukumari Medical College Hospital and Research and consultant at Chitra's Hospital. Welcome, ma'am. I now request our chairpersons to introduce our first speaker today, Dr. Gaurav Desai.
Good evening. I welcome Dr. Gaurav Desai for giving the talk on morbidity and mortality after PPH. Is it a system failure or cognitive failure? Welcome, sir. He is a visiting pelvic endoscopic and robotic surgeon in Mumbai, PD Hinduja and Gleneagles Holy Family, Mother Care Nursing Home, Breach Candy Hospitals, Faculty Safe GSMC and Chem Hospital, author of textbook Principles of Obstetrics and Gynecology. He has over 40 national and international peer-reviewed publications, and he's a member of MCM, MOGS, IAGE, and FOGC. Welcome, sir.
Okay, thank you so much. Can I share my screen? At the outset, I'd like to thank Sampath Kumari Madam and the organizers for this webinar to allow me to speak. Is my screen visible?
Yes, sir.
Yes, sir.
Okay. So this is a little different talk from the usual talks on postpartum hemorrhage. The disclaimers I have to mention are that this is not a theoretical lecture. So it's not going to be very boring, or it is going to be a little different because this is something that I have been thinking about for many years since I practice high-risk obstetrics at one of the largest tertiary care centers in the country, where we specifically look at pregnant women who have high-risk disease. We have so many protocols, we have so many books which are written, guidelines by various organizations on this topic of postpartum hemorrhage. But we really need to find a conclusion or at least get some closure on whether it is the protocols that are the only thing which is important, or is it something else? So I bring greetings from the city of Mumbai, the maximum city. And most of you all, of course, might know me as a minimal access surgeon. I also practice minimal access surgery at some of the hospitals, and robotics is one of my interests. But I have been fortunate enough to teach students, residents, as well as fellows in various training programs across the country, and also represented at platforms like the AMOGS and SAFOG. This is one of the places where I teach students. It is a tertiary care center, which also gets a lot of patients of high-risk obstetrics, where we have good collaboration with various subspecialties like neurosurgery, nephrology, cardiac surgery, just to name a few. So we'll come to the topic directly. We'll look at what the obstetric shock is. By the time I basically give this lecture and by the time this webinar is over, a few women would have died around the world of postpartum hemorrhage. We have various advancements like robotics, but this disease still haunts us even today, and it will keep haunting us unless we cover up all our bases. So this is despite our guidelines, despite the various drills, conferences, educational programs, oxytocics, uterotonics, all the new pharma drugs that are coming in, despite all the WHO bundles and the various initiatives taken internationally as well as nationally. So what is the question? The question is knowledge really the problem? We know quite a bit about all these. They are well documented. We publish several books every year, reiterating the highlights and important aspects about managing PPH. So the uncomfortable truth is that we don't really lack protocols. What we lack is recognition speed, we lack escalation courage, and we lack cognitive clarity under stress. Basically, what we lack is just the cold decision making that has to be taken. And unfortunately, emotion is mixed with our decision making in most cases. Most deaths in PPH are not really from bleeding. They are actually from delayed thinking. So let's conduct an autopsy on our brain. It's called the cognitive autopsy. So when a woman dies of postpartum hemorrhage, ask yourself, was the protocol unavailable or was the mind unavailable? Just think over this slide, introspect within yourself and think about the slides that I am showing. So a case for curiosity, this is a fairly common scenario. Maybe some of you all might have experienced this in your career. A 26-year-old primigravida, the delivery is fairly smooth, uneventful. Oxytocin is given as per the protocols. Bleeding seems moderate. The blood pressure is about 100/60, pulse is 110. The resident or a staff nurse in a nursing home says she's anxious, thoda घबराहट हो रही है, these kind of comments. 30 minutes later, she's crashed. So what really killed her? Was it atony or was it a normalization of tachycardia? So we look at the first cognitive error, which is normalization bias. We always tend to normalize abnormal signs. We want them to be normal. We want things to be uneventful. So tachycardia in labor is common. It's because she's under stress. Post-delivery bleeding is expected. As we say, it happens. So let's try and normalize it. By the time it becomes abnormal, it is actually too late to react and do anything. So PPH is a systems failure. It's not actually just uterine atony. It is a failure to anticipate, failure to mentally rehearse that situation, failure of hierarchy clarity. Nobody knows who's the boss in the labor room. Failure of decisive leadership. So PPH is a team cognition crisis. Now let's look at protocol versus the performance. So we all have these protocols. Some of them, I know there are some Foxy Figo charts which you can put up in the labor ward. We have them across nursing homes, clinics, institutions. These protocols are linear, but unfortunately, reality is not linear. The WHO postpartum hemorrhage bundles are excellent in that they are very efficient, but humans don't really think in flowcharts. In a chaos. Like if you ever have recollect your mind when a patient is actually torrentially bleeding, I bet flowcharts and linear protocols are definitely not in the mind. It's absolute chaos. So in KM Hospital, we have a common room where we sit and have coffee and tea and sometimes lunch. And I happen to make friends with some neurosurgeons who I also collaborate with. And we got into a discussion on what happens and why our brain just doesn't work. So they told me that, when there is stress, our prefrontal cortex basically shuts down. Okay, this is just a human tendency. So under acute stress, our working memory drops, decision speed slows, and tunnel vision develops, typical of prefrontal cortex shutting down. So basically our adrenaline, all that excitement narrows our cognition. So the uterus is bleeding, but the brain is freezing at the same time. Now, what are the three cognitive delays? just like we have 3 delays in postpartum hemorrhage, what are the 3 cognitive delays? A delay to recognize severity. We don't really see how severe the disease, how severe the event is. The delay in escalating. Maybe we know how severe it is. She is torrentially bleeding, bled 2 liters, 3 liters, but we are hesitant to escalate that action, and a delay in deciding surgery or an intervention. So whenever we are sort of procrastinating and wondering what to do, she is basically losing a lot of blood, sometimes maybe 500 to 1000 ml. Now we come to the next case. So this is also a common scenario where a senior consultant or the practitioner arrives in a labor ward and sees blood on the floor, basically says calmly, "Why wasn't I called earlier?" So the room is silent and the staff nurse or the junior says, "We thought it would settle, but it didn't settle." So that sentence basically has killed thousands globally. So I call it the "it will settle" syndrome, where we overestimate uterotonics, massage, hope, and we underestimate exponential blood loss. Bleeding, unfortunately, does not follow a straight line. It is exponential or geometric. Now, the other aspect is that there is a cognitive overload in our labor rooms. Whenever a situation like postpartum hemorrhage happens, there are many simultaneous distractions. So you have family pressure, relatives are asking what is going on. There are neonatal concerns. Maybe the child is delivered but didn't cry immediately after birth, or you're always wondering. Pediatrician sometimes is talking simultaneously, saying baby didn't cry, meconium hai, so we took her up to the NICU. So that is going on. Then the whole problem of documentation, there's a chaos going on, but you have to still document who you're calling, what you're doing, any intervention, blood that is being given. So phone calls which have to be made, you have to call other people to help out, consultants, other specialists, ICU, hierarchy dynamics that are also taking place. Sometimes you may not be the boss and you have to call your senior. So all that is going on at the same time. So unfortunately, the brain has some bandwidth limits. Now the authority gradient. So basically the junior consultant sees the danger, but sometimes what happens is the first time you approach a senior, this happens in institutions, the senior takes it as a first, how do you say, first warning. So the senior sometimes dismisses the first warning, and the outcome is basically a delay. The senior doesn't know that the junior has waited for a very long time before the junior has informed the senior. So that is something that happens. In high reliability industries, like basically any corporates or some sort of structures, multinational companies, whenever there is a crisis, there is basically no hierarchy. So everyone is at the same level. So all these industries flatten the hierarchy during a crisis, and that is something that we should learn from when we are practicing. Now we look at the aviation comparison. This last AICOG was in Delhi, and after it finished, on the way back, I was sitting between 2 pilots. I happened to be sitting between 2 pilots, and we got talking, and we basically started discussing about emergencies, because they are also handling sometimes emergencies, and the similarities between obstetrics emergencies as well as in aviation. So in aviation, basically checklists which are there are verbalized, means they are said aloud. The roles are pre-assigned. Everyone knows what to do. And the crisis simulation is routine. So basically, even though there are millions of flights that are taking off and taking on each flight, the air hostess will basically simulate what to do in an emergency on every flight. There's not one flight where it is missed out. So this is what we should learn in obstetrics. So we often simulate basically only for accreditation. So we have to be honest about that, and not for survival. Now, a controversial slide, the myth of experience. So experience does not always equal to immunity from cognitive bias. Sometimes senior doctors and consultants may delay the hysterectomy longer. They might, there's always an emotional element when one is removing a uterus from a young woman. You are basically cutting short her reproductive life. Uh, and especially sometimes if you know the family or you are sort of related to the patient, then this of course plays a role. Even a few seconds or a few minutes can mean, the difference between morbidity and mortality. Now, um, senior doctors may also overtrust uterotonics. We have so many new drugs that are coming in by pharma, and they all promise to be better than the other drug. So we always hope that we can save that patient's life with just the help of an injection. And sometimes they may fear even overreacting. So wisdom, unfortunately, sometimes resists escalation. Now we come to the second cognitive error, that is optimism bias. So we always think optimistically, we think that we have handled worse situations. And what is this? It's a simple case. It should not be a problem. Yes, we all have handled worse situations, but sometimes situation can escalate. And in that case, we haven't. Now, the question is about data versus ego. So evidence shows that early escalation reduces mortality, but escalation feels like failure. So is our hesitation about patient safety or is it about professional ego? So I don't know if some of you all might recognize this statue. He's a famous thinker. Some of his statues are in the countries like the United States. So some proverbs for reflection and thought is a stitch in time saves nine. Hope is not a strategy. And when in doubt, act. You can always apologize later. So some micro delays that kill are those 5 minutes which are waiting for blood, waiting for a consultant, waiting to decide whether to take inside an operating theater, and waiting for the consent of relative, husband, etc. PPH unfortunately does not wait for anything. It basically punishes all this hesitation. So now, what is the cognitive solution model? Is we need to shift from this protocol-based care to cognition-trained teams. One needs to train in your own setup, in your own teams to basically warn them or sensitize them for early trigger thresholds, to have automatic escalation pathways which leave aside any ego or leave aside emotions, and a zero blame activation. So for instance, red flags triggers which have to be hardwired into all our protocols and systems is that there should be a mandatory activation if pulse is more than 110 or shock index more than 0.9 if she's bleeding for over 10 minutes. So this has to be basically potential maternal morbidity mortality unless it is controlled, not the other way around. So there's no debate and just activation. So the third cognitive error is the diffusion of responsibility. See, everyone sometimes is present at the scene of postpartum hemorrhage, but no one is leading. Everyone is looking at each other. Who's the boss? PPH needs basically a commander, someone who is ready to take the lead, someone who's able to communicate not only amongst the doctors, but also to the patients and the relative. A basic recorder, a documenter, and someone who is able to take a snapshot of that entire scenario that takes place, and a transfusion lead. Now, the surgical hesitation dilemma is, when do we decide to do a hysterectomy? Always an OH is difficult to do, but if it's too early, then there is always regret. And if it's too late, there is the question of facing death. So courage in PPH is not an aggression, it is timing. Now, the final question is, if a woman dies in PPH even today in 2026, I mean, decades after this disease has been known, is it because we didn't know what to do or we didn't think fast enough? So think about that. So to conclude, protocols have saved women, but cognition saves them faster. PPH mortality and morbidity in 2026, in the 21st century, is not a knowledge gap. It's actually a decision speed gap. So ask yourself, if the next postpartum hemorrhage case starts in your labor room or your institution tomorrow, is it a protocol failure or a cognitive one? Thank you.
That was a very excellent talk, sir. A different perspective of PPH, the cognitive this thing, and the time to intervention delay. It was a very excellent talk, sir. A totally different perspective of PPH. Thank you so much, sir.
Thank you. Any questions?
Individually managing may result in all such problems which you have mentioned, but immediately they should get hold of help, a friend or somebody. In that case, definitely the other person can calmly think how to manage, because the same person will be in distress, confused. So this other person who comes for help can definitely think and then do whatever you say, isn't it?
Yeah, so I mean, since I face all these situations on a day-to-day basis, usually the people coming in afterwards tend to give their own advice at different points in time. But the advice actually should be the person who's seen that patient right from the start. So, because if, for example, if the person, she's already lost 1 or 2 liters of blood, and then somebody comes in after 5-10 minutes and says, let's wait and try uterotonics, and she's again lost some more blood, then the third person comes in, again says the same thing, because that person has just seen her losing a little bit of blood. So, but the first person has actually seen her lose 3 to 4 liters in that time. So, that is where all these delays, and everyone has an opinion today. And sometimes everybody's opinion is not important. It is the person who has seen her right from the start.
So, Gaurav, that was a very good talk from a different perspective. But I think in any case of antenatal patient in labor, we have to anticipate, group her first, whether she is high risk, prone for PPH, anticipate PPH, get ready the team for all the prophylactic drugs, and always follow up the PPH bundle in the initial phase itself. See, be calm. That's the most important thing, I think. Any obstetrician, and that too, senior obstetrician should be available. If not, like a smaller hospital, then they can call for help. But before calling for help, always try to initiate the treatment for PPH, anticipate, start treatment, and then execute everything. So by that time, I think it will be, if you are anticipating, if you are following up the protocols, I think we will not get into problem. Even if it is a smaller hospital, keep on giving drills for the labor ward staff. And my wish is always, I keep all my labor ward staffs permanently. Like I don't keep changing them. So periodically we should go for drills. So these people will know if the patient is a high-risk patient with multiple pregnancy or obesity or polyhydramnios, they will be ready. See, they will, instead of oxytocin, they will give carbetocin. Start the patient on, they will have every set of uterotonics. So that should be the first PPH bundle should be executed. So I think that will definitely help to reduce the primary thing. Then, as you say, if it is going profuse in spite of all the atonicity alone, we cannot think. We have to think in terms of trauma also. That that we have to analyze whether it is a vaginal tear, because we see quite often vaginal tear causing so much of bleeding or the cervical injury. All those things we have to just keep on going for a drill. That is essential. Teamwork is essential. I think that will definitely reduce, like having a anticipating not only the uterotonics, but we should have the like the panicus cannula, which I find very useful, because even if it is going to be a placenta previa, putting panicus cannula during the surgical procedure definitely helps. It is not only for the upper segment, but even the lower segment it helps. So I think we must be prepared, then execute, and a teamwork.
And one more thing is that this mock drill you tell, comparing with that pilot, that is really a very good example.
Yes.
So simulation protocol must be
there.
taken
Periodic
place.
stimulation
And
protocol.
one more thing is that the private practitioners, I think they can have a sort of a training like program in the government institutions, large institutions, where they tackle such problems. So unless they see how it is managed, they can, if they see that, definitely they can practice the same in their own place also.
Yeah. So, I'll give you an example. Since I'm both in private practice as well as at an institution, my residents and fellows at the institute see postpartum hemorrhage very frequently. So it's a well-drilled unit and a department. But this is not always the case in outside in smaller nursing homes, where they may, have one patient who is high risk of postpartum hemorrhage maybe in 1 year, sometimes 6 months. So they are not used to seeing these patients. In an institute, we always teach them, and my father is from the same institute. So we were always taught that every patient is a potential mortality.
Yes.
So manage them accordingly. Whereas sometimes in a nursing home or when people find, into brackets, low risk patients, they sort of become very, how do you say, lax or very relaxed. And suddenly PPH comes up as a surprise to them. So that is, it is basically a cognitive, it's your mind which you have to train, and you have to keep your mind open to the potential of maternal mortality.
Thank you, Gaurav.
Thank
Fantastic.
you. Yeah, thank you, madam. All the best for you. All the best.
Thank you. All your supports need.
Thank you. Okay.
Thank you.
Good night.
Madhumita, we can go with the panel. Madhumita, Prantnya. If no one is there, I will introduce.
Yes, ma'am, I'm here. Yes, ma'am.
Yes, ma'am.
Pradnya ma'am will introduce our moderator, expert, and panelist.
Yes. Okay, Madhumita.
Madhumita, you introduce.
You introduce, ma'am. Girjawag ma'am.
I'll introduce.
Yes, ma'am. You introduce, ma'am. Yes, ma'am.
So we have a panel discussion on difficult scenarios in LSCS. Our moderators are Dr. Girija Wag. Yeah, Madam is Professor and HOD, Department of Obstetrics and Gynecology.
It is okay.
Pragnya, strict teacher. Ajay Mane told no, strict teacher.
Strict teacher. But Madam, we are glad to have you here with us today.
Thank you so much.
Our expert for today is Dr. Ramani Devi, ma'am. Ma'am is President TNFOG 2024.
Yeah, that's enough. Past Vice President Foxy, that's all.
Thank you, madam. I would like to introduce our panelists for today. If I can, we have Dr. Sujata Devi with us. Madam is consultant.
That's fine. That's fine.
Thank you for being here, madam. Our next panelist is Dr. Supriya Arwari. Madam is consultant obstetrician and gynecologist. She is also
it's okay, my dear. It's okay. It's okay.
Adolescent committee chair.
Yeah, that's it. Committee chair.
For being here, ma'am. Our third panelist is Dr. G. Prema Priya. She is from Vinayaka Missions, Kirupananda Variyar Medical College, Salem, Tamil Nadu.
Thank you, ma'am.
Now you are orator.
You are orator.
Thank you, ma'am.
Our next panelist is Dr. Sheetal Potode Patil. He is consultant.
Thank you.
Multi-speciality hospital. Our next panelist is Dr. M. Sudha. Madam is Professor, Department of OG from Madurai Medical College. Welcome, madam.
Welcome.
Dr. Vijitra, she is consultant at Vijay Hospital, Karur, and secretary for Foxy Karur. Dr. Anita Thanasekaran, she is consultant team Specialty Hospital, Pudukkottai, secretary of Pudukkottai OG Society.
Thank you.
Yeah,
Thank
new
you. Thank you. You
society.
can continue.
Thank you,
Yeah,
madam.
new society.
Dr. Monisha Dev, she is assistant professor at Sri Muthukumaran Medical College.
Yes, she is the youngest of all, I think. Anyway, we'll start the panel.
And Dr. Urvashi Balakrishnan, Dr. Madhumati, and Dr. Saili Jagirdar, who was currently the secretary of the Yuva Foxy Amravati, a very successful conference. So I welcome all the moderators and panelists, and over to you, Girija ma'am.
Hello.
Hello, ma'am.
Yes, Dr. Girija.
Hello.
So we have a whole plethora of panelists. Are you able to see my presentation?
Yeah.
Yes,
Yeah,
yes,
we have
yes.
been there. Yes.
Okay, so today we have been given a task to discuss the challenges at C-sections, and it is such an important topic to be discussed because we all know that C-sections are on the rise and we have to be a little safe. And I want to congratulate Dr. Sampath Kumari madam for coming up with this wonderful innovative idea of aligning with the AMOGS, which is our state society, and bringing us this wonderful session. And I wish you all the best, Dr. Sampath Kumari, for your endeavor.
Thank you, Dr.
I can see
Girija.
how hard you are working, and
Thank you,
I'm
thank
sure
you.
success will be yours. And there are
Thank
many stalwarts who are here, especially Madam Ramni Devi, who is an expert. Thank you, Madam, for being here. And always she helps us in guiding us. We had a wonderful talk on PPH by Gaurav, and that was excellent, and a different aspect and a perspective, which is very, very important. And Sujata Dalvi, Madam. Supriya Arwari is there or not today?
Yeah. Everybody is there.
Everybody is
You
there.
start.
So we will now take the panel. I think I have planned it for 45 minutes. I hope that's right, because we should not unnecessarily come in the way of our bedtime and studies. And these are all the expert panelists from young to very experienced one. I don't like to say old. So we'll be focusing on non-engaged and deeply engaged heads, incision extensions, dry delivery, and crash C-section in this panel. There are so many other difficulties also which we encounter, but we have to understand that not all can be, and every C-section, since there are youngsters here, I would want to say and share the fact that every C-section is unique in its own way, and therefore we have to be always prepared for any challenges. Like how Gaurav said that PPH can happen even in a normal patient, so-called normal patient. C-section difficulties can be encountered even in absolutely a completely non-morbid patient where we would be taken on a ride. And therefore, it has been quite some time now that we have to understand these things. Even if the WHO says that the incidence of C-sections is 15%, we are experiencing different ratios completely in our country for various reasons and in our facilities and in our personal as well as institutional practices. And therefore, possibly we are thinking of too many or too few, or maybe it's both. Now, I'm going to ask this question to the most senior person on the panel, and then after that, a difficult question will be for her, Dr. Sujata Dalvi, madam. And overall, C-sections are on the rise, and optimization of the operative procedure and minimize complications has become the need of the hour, we understand. So what are the gross checklist pointers that must be considered before a C-section delivery? I would like to hear from you words of wisdom, because we want to know and ensure that we don't go wrong.
Yeah, so before we decide on a C-section, there are some checklists that you need to figure out. So patient is registered with you antenatally. So you need to figure out whether all the blood investigations are in their place or no. In case the blood investigations are very old, then we need to have a recent blood investigation. It's a protocol in our hospital to have an anesthesia fitness, whatever it may be. Of course, there are emergency times. You take a C-section, anesthesia fitness may not be there. But if it's little bit of a the thing planned C-section anesthesia fitness has to be there. Otherwise, anesthetists generally don't like to induce. Any patients above the age of 35, they would want to have at least X-ray, not X-ray, sorry, ECG and 2D echo. And any patient who comes in labor, whether she goes in for a C-section or this thing, one blood for grouping, cross-matching, and one unit is always reserved for that particular patient because there is no gap. Of course, if there's a facility, maybe two, but it is minimum of one. And PT-INR has to be done just at the time of admission and at least a hemoglobin at the time of admission. If viral markers are more than 3 months old, then they want to have it repeated. You need to inform the neonatologist well in advance because there are at times it has happened that the neonatologist is not available and that's the reason C-section has been postponed because he or she is not available. So these are the, when anybody who has a comorbidity, then we need to have a fitness even from that particular field, like a medical field, whatever it may be, hypertension, diabetes, whatever it may be, that needs to be done. And of course, high-risk consent has to be taken for the high-risk type of the patients that you need to explain whatever it is there and make sure that at least one relative is there with the patient so that in case of any need or anything, you can inform the relatives. So these are the few things that we always make it a point to keep it in mind before we plan for a C-section. And of course, trolley and this and that, that's for the paramedical staff to check in the OT.
So excellent summarization, madam. And I want you to know that on the Foxy website, we get this consensus statement of C-section. We have the pre-op checklist to do and confirm and a post-op checklist for the doctors as well. And there are various such Foxy checklists which are available, which you can use them. And this is another checklist of C-sections, which madam summarized so beautifully. So, and madam has her whole body of expertise for a long period of time. So these things come to her very easily. It's always better that we have these visual assistances and our teams are ready with identifying these things. So there are various things such as protocols, intra preparations, and instrumentation, post-operative checklist, and also a guideline as to how you can create your own audits so that you are better next time in case there's a problem. Now, my next question is going to go to Monisha. Dr. Monisha, you are there?
Yes, ma'am, I'm here.
Yeah. So there is Nikita, who is a gravida 4 with 2 abortions, who conceived with pre-pregnancy weight optimization, postpartum resection, post-septum resection, and has reached 39 weeks and has requested for elective cesarean birth for ultrasonographic finding of 2 loops of cord around the neck. And she has had weight gain of 17 kgs during pregnancy from 72 to 99 kgs and late onset GDM. Her expected baby weight is 3.957 grams. It's a cephalic presentation with a floating head and her placenta is fundoposterior. So how are you going to now visualize the challenges that you're going to get and deal with this, not only a big baby, but also delivering a floating head in this particular patient?
Yes, ma'am. It is always advisable to do an on-table abdominal examination to check where the position of the head is. And the patient had bad obstetric history and she has a septal resection also. We always have to examine the patient and then proceed on with the regular incision, uterine incision, low transverse incision and Kertz incision. We proceed. And I have the habit of fixing the head and then only retrieve. And the new residents who is doing the cesarean section for the first time, they have the habit of holding the head with the fingers and also the thumb. It's always to lever out the head and not to use the thumb and hold it like a ball. So we just lever out the head. If at all it is not possible, we can do a vacuum extraction or an outlet application also. But
Okay.
it's always, I always prefer to fix the head and lever out. That will be easy for me, ma'am.
Yeah.
Floating head. Can give fundal.
Yes, you can do a fundal stabilization of the baby as well, because if the liquor is more, the abdomen is pendulous, you can have the baby moving and changing its position. And actually in this particular patient, it did happen that while we were trying to leverage and all, it suddenly turned and I had to do a breech delivery because there was a huge pendulous abdomen that this woman had. So we have to be careful, and that's the reason why I brought in this particular case here. And I would like to ask Dr. Supriya, you're there, Dr. Supriya Arwari?
Yes, ma'am.
Yeah. So any other nukhas that you can use, in a floating head?
Ma'am,
Like she
already.
very beautifully told us what she would do.
Yeah,
And I
yeah.
told you what I encountered. Now you
Yes,
can
ma'am.
tell us what can be done better.
Ma'am, for floating head, number one, if there is too much of liquor, then draining liquor under a little control will help reduce the volume of the uterus, will help the head to stabilize a little, and then maybe we can try delivering a head. Personally, ma'am, I'm a champion of vacuum extraction. There has been a description of using Vectis or single blade of the forceps, but I have never tried that in practice. But most of the time, vacuum extraction works. With vacuum, just one nice incident I would like to relate how we sometimes forget to counsel and take things for granted. I applied vacuum on the on table, delivered the baby. After delivery, because I use vacuum very often even in my normal deliveries. After delivery, the Sasuma came and asked me, Madam, you have done cesarean delivery. How baby has got a vacuum? This talu कैसे इतना बड़ा हो गया? ये तो आप नीचे से डिलीवरी करते तभी होता है. So I said, sorry, I forgot to mention that I delivered the baby by vacuum, and you can have a little bit of that caput and it will eventually go. So just one rider to that. And yes, otherwise, other things what she has told is excellent, that, the direction of how you put your hand in and you try to just flex the head. So that is other trick, that find out where the occiput is, go in, because often when it is floating, it is possible that it is a deflexed head. So you go in, try to flex the head. Once you flex the head, by the nature of things, the smallest diameter will present at the scar, and we will be able to remove the baby more easily.
Absolutely. So I think we
Madam,
have
I would
done.
like to add few
Yes.
points, madam.
Yes, yes.
I'm Dr. Sudha from Madurai, madam.
Yes, my
Yes,
dear.
as she said, floating head, you have to fix the head, let out the liquor, and then you have to deliver. Otherwise, if the head goes away, you have to deliver it by breech presentation. Or we can use one single blade with the forceps and you can deliver.
Absolutely.
Yes,
Thank
madam,
you.
I mentioned that, yeah.
So
Yeah.
first and foremost, I think even choice of your incision has to be proper. It should not be as low as possible. It should not be on the upper segment. It has to be just there at the widest portion on the lower uterine segment. And while you're widening the incision, it's better to keep the membranes intact and then drain the liquor so that your incision is not too short for a big baby and unnecessarily you don't land up extending. And yes, all of you have given wonderful inputs, and I'm in love with forceps delivery because maybe in Sassoon Hospital vacuums never worked, and therefore we always used forceps, and we are expert in using forceps, and that's how we can.
Girija?
Yeah. Yes, madam.
Yeah. This delivery in a floating head is really, it needs an art.
Yes.
Like everybody has said, we are expecting a big baby. So I think our incision should be quite enough, both the skin incision and the uterine incision, because many a times I have seen patients with a normal, like a routine skin incision, they'll be having a difficulty in delivering the shoulder, not only the head. That also comes. So I am 100% in favor of delivering a floating head only with forceps, because forceps gives a controlled delivery. You can identify and then you can flex so that it will not, the extension of the angle will not be there.
Absolutely.
So that is one thing, as others have mentioned, like slowly drain the liquor and then you can go in for a forceps application or with the hand. But I think with the hand, the delivery of floating head may be slightly difficult, or at the most, if it is oblique, if you're not able to get it, I think deliver by breech. That will be the ideal one.
And I think we should always remember that we are women, very petite women. Our hands are very sweet and small. So instead of just working with your fingers, you should entirely put your entire hand inside and then manipulate. That makes life easier. Rather than, because many of our male colleagues are just doing it so easily. And we find that ye to apne ko nahi jana. So we have to understand this as well. And when you're using the instrumentation, the principles of instrument application in the baby's head are the same as are for the vaginal birth.
Yeah.
So if you're using a vacuum, it's always better to look for the pivot point. If you're applying the forceps, it's always better to have the correct cephalic application because here there is no pelvis for you to contest, and it's very important. If you are using a Wrigley's forceps, which has a curve, it's better not to. It's always better to use the short Simpsons. But if you're going to use the Wrigley's, you should see where the baby's head is facing so that you don't land up in unnecessary challenges. So these are small important tips that you can remember so that you are able to use the instrumentation correctly and fearlessly. And of course, then Dr. Sudha madam did tell us
Can I
that yes,
just say one thing? The forceps blade, it's always posterior and anterior. So always put the posterior blade first and then only anterior. It is not sideways. So that they just have to remember. We also always have forceps on our trolley. Vacuum is rarely there. So we are also quite used to using forceps, which is always
we
there
do
in
have
all
electricity
C-section
and good
trolleys.
suction
So
machines
it's
now.
always the posterior blade first and then the
Anterior
anterior one on the upper one.
Sometimes we can rotate it comfortably. After application of the forces, you can rotate it so that you deliver with a narrow part of the head comes out.
Correct.
And flex it also. You can flex the
flex it.
Yes.
The same
And
principle.
one more point in forceps, we can autoclave it very good. Very good.
Yeah.
Excuse me, you can also get the help of the assistant to fix the baby.
Yeah.
That's always.
And yes, and then like if I land up in a problem like I landed up, then maybe we can, when the head floats away, then without getting scared, you can just reverse the breech and deliver by breech extraction.
Most of the time it also occurs.
So even if you have started doing C-sections for breech births, always be prepared. You may have to deliver them still and use the same maneuvers. So therefore, we have to never forget our art of obstetrics, even if we are doing C-sections, is what a message that I must give at the end of this discussion. Now I'll come to Urvashi. Dr. Urvashi, you are there? Because some of you have not renamed yourself. I'm not able to see. Is Dr. Urvashi there? No. Dr. Prema Priya? Okay,
Yes,
Dr.
ma'am.
Sheetal is there.
Hey, Dr. Prema Priya is there.
Okay,
Yes, ma'am.
Prema, please rename yourself, beautiful girl. So we have Praveena Prema and gravida to para 1 at 40 weeks, and she has an expected birth weight of 3.4 kgs in spontaneous labor. There's an optimum progress, and there's a spontaneous rupture of membranes at 7 centimeter, full dilated for the past 40 minutes now. CTG is showing late results. Station is 0. There is right occipital posterior first degree molding is experienced on the baby, and emergency C-section is decided. So now you are seeing that this is a
Second stage LSCS, ma'am.
Second stage LSCS.
She's fully dilated and it is right occipital posterior. The baby's weight is also 3.4 kg, ma'am. And she's in second stage for almost 40 to 60 minutes. So I expect there can be a second stage LSCS, like a deeply engaged head can be there, ma'am.
Yeah, so I would want to also make you understand that 40 minutes being in dilatation is not a big deal in a posterior position.
Yeah.
But here there is late deceleration.
Deep transverse arrest. It could be a deep transverse arrest also.
It's not a DTA. It's a right occipital, persistent occipital posterior position. Okay.
Yes, ma'am. Yes, ma'am.
There are late decels. That's why we want to take a section. We are not taking it because if the patient is in the second stage, we all know now today, we can wait up to 2 hours as well if the baby and the mother are fine.
Deep transverse arrest, we will say only after 1 to 2 hours of full cervical dilatation.
Yes, correct.
So,
patient.
so this is not for the second stage 40 minutes. It is for the late decels.
Late
And we all know that
deceleration.
late decels are definitely worrisome for the baby. So if there are late decelerations, we now decide, and yes, as you rightly said, it's a second stage C-section 1, 2, it may be a impacted head, which may be deeply impacted. So now in such a situation, what would be the common pitfalls you need to avoid in this particular case?
First
thing. Shall I answer, madam?
Yes.
Yeah.
And Dr. Sudha, shall I answer?
Yes, Dr. Sudha.
Yes, madam. In this case, the bladder will be drawn up. So we have to put the incision mostly by midline incision, not fan and steel incision. Open the general peritoneum as high as possible. Because you may, the bladder is maybe drawn up. And you have to put a stay suture in the lower uterine segment. That is very important. And you have to put the incision just below the reflection of the UV fold of peritoneum. And you can deliver the baby by because the shoulders will pop out, you can deliver the baby by push technique or pull technique. We usually follow the Patwardhan's technique. We will deliver the anterior shoulder first, then deliver the posterior shoulder, then the trunk, and finally the head. Or you can deliver by modified Patwardhan's method. Anterior shoulder first, and same side leg first, second. Then you can deliver the posterior shoulder, trunk, and then the baby. Push technique is we put a hand into the vagina and push the head up, but the disadvantage will be infection and extension of the uterine incision.
You can ask the assistant to push the head also, ma'am.
Yes, so you can
From
take the
below.
assistant to push the head from below. Okay.
Yeah,
anything else?
infection rate is very high, no, madam, in that.
Not
And
like that.
Anybody wants to say anything or contradict anything that madam has said? She mentioned a vertical incision.
Vertical incision.
Yes, it was not needed, not needed. Not always.
Not needed. No vertical.
Even with a financial incision, you can perform the same procedure.
Yes,
Yeah, now can you tell me, in case if we have performed the financial incision and you find that the space is not adequate, what can be done then?
Muscle cutting.
You can extend the incision
can
with a
do a
muscle
male
cutting
T-shaped
incision.
or J-shaped we can extend, ma'am.
J-shaped. Oh, no, no
On both
T-shaped.
the sides.
Not male
J-shape.
large. You
Rather
can
than
just cut the
T-shape, you can
muscle.
have a muscle cutting incision, the Maillard's incision.
Correct. So
Or
male
the primary incision can be slightly at a higher level. Not the routine Fenon steel, but put it at a slightly higher level, like Joel
coin incision.
Yeah. You can
And
push
also the
it from
incision
below.
of the uterus should be a little higher.
Yeah.
Just at the junction of the upper segment and the isthmus.
Lower
You can say,
segment.
because
She did
in a
mention
fully
that just below
dilated,
the
fully
just below the
dilated
nipple.
cervix, the cervix gets taken up, and therefore after we might incise on
Till
the
we
cervix
open the
area
cervix.
and then we open the cervix. So take a higher up incision, and then you get all the chance in the world to reconstruct the parts and suture it well. Just don't go too lower, like we routinely try to go
Because
as
if
low
you
as
go
possible.
too lower in a second stage C-section, there's likelihood that you may cause
Vagina.
sending
Yeah.
cervical injury, which is very
Yes.
difficult to cover.
Cervical injury, bladder injury, it's just a, even if it's a previous illness, madam, my experience is we don't even dissect the bladder. We don't go that level, just take an incision above the reflection of the bladder, forget the bladder, let it go down.
Yeah, I usually put the incision without separating the bladder.
Yes, ma'am.
Just
Even I do that.
automatically
All the
It should
time.
be quick enough to deliver the baby also.
Yeah.
So naturally, there is a algorithm like, does the clinician have training expertise in reverse breech extraction pull method? Perform the reverse breech extraction, successful, unsuccessful. So all these protocols are there, and these are various maneuvers such as the pull method, the abdominovaginal delivery, that is the push method, or the Patwardhan's technique, which is called as shoulders first, fetal head elevators, T or J incisions, and these are usually techniques which you should try and avoid. So I would like to listen to Sujata Dalvi, madam, especially when it comes to Patwardhan method, because a lot of us youngsters haven't directly seen sir doing it or performing or practicing. And I'm sure madam can give us some insights into this. Yes.
Yes. So in case my hand doesn't go lower down, and if I feel it's going to be difficult, I don't break my head too much into it. I would straight away go in for a Patwardhan's method. So Patwardhan's method is a shoulder. You just take out one shoulder. If the back is anterior, you have to take out the opposite shoulder also, and then slowly and gradually pull the baby. But when you're trying to pull the baby, make sure that you don't put too much hand onto the baby's abdomen. Otherwise, there are chances that you could damage either intra-abdominal organs. So one has to be little careful when you're trying to pull. So a little bit of a funnel pressure from the assistant is necessary. And the moment you can remove the whole of the baby's abdomen, both the limbs will come out. And the moment both the limbs come out, the head just automatically comes out. So you don't have to bother about it. There are at times the back is not anterior, but the back is posterior. So when one shoulder comes out, you trace that and you trace the back and you take out the lower limb of that particular side. And once you take out the lower limb of that particular side, the opposite lower limb will be able to come out and you will be able to remove the baby. And then the head automatically comes out. You don't have to do anything. But these are the things which it cannot be taught to the resident who is attending at that time. They only have to see, and you can teach them in a some stimulation center or, some exercise or something of that sort. It is difficult to teach them on table, especially when you're trying to do such a thing. But it is not very difficult and you can still do it rather than putting too much hand inside and then damaging the lower uterine segment. No, not lower, sorry, the vagina and the bladder and things like that, So this is much better than in that case.
Yes, and so there are certain modernizations also which have been seen, such as the coin spoon assisted delivery. As you can see here, we can use even the forceps as a vectis. And here you can see that the spoon has been pushed inside the vagina and the baby is being taken out and delivered. So such kind of tactics can be considered and used, and we can help, relieve the mother from these problems. There's also a lot of body of work and publication on the fetal pillow. Anyone here has an experience of seeing or using it? So this is a very typical fetal pillow which has been pushed inside the vagina. It is deflated and then you pump it. And then it will elevate the baby's head gently so that you can deliver. And this is something which is also recommended by the NICE guidelines. And of course, I don't think we have the access to such things, but we must think and make our own innovations in our country so that we are able to deliver these babies safely. Now let's come to Sheetal. I think Sheetal didn't get time to answer last time, so I'll ask her this question now. Sheila at 36 weeks presence with PPROM, 6 hours as per her history. Expected birth weight is 2.8 kgs, AFI is 1 centimeter, augmented with oxytocin and progressed as per the partogram till 8 centimeters. Station is -1 now. She had variable decelerations which persisted for an hour despite resuscitation, fluids, left lateral position, and was taken for an emergency C-section. On the table, her fetal heart rate confirmed to be 120 beats per minute, and the uterus was full of baby with negligible liquor. So now here we are coming on the conundrum of no liquor at all. So what are the various difficulties that you will foresee and try to tackle them and overcome any kind of these difficulties?
While taking incision in severe oligohydramnios, you can injure directly fetal scalp or fetal head. So just precaution to be taken, not directly take the uterine incision very deep. So just gently, you have to give that incision, and after seeing just membranes, you just stop it. This is the first one. Also in oligohydramnios, again, impacted head can be there. So you can also deliver it with forceps.
Yes. So maybe you can consider all of these things, but you have to remember that here the lower uterine segment may have started reforming.
Reform,
And
yes.
it's not absolutely as good. So sometimes we feel कि ये तो LUS है लेकिन इतना thick क्यों है? So this is probably reforming because the baby is too small and the uterus is trying to push it down.
And madam, the uterus grips the baby when the liquor is absent, so any
Correct.
manipulation is very difficult.
Correct. So therefore, we have to be careful because these are going to sometimes some people have done extensions like inverted
While
T.
putting
and
incision, it may land upon the baby also, madam.
Yes. So you have to be careful that you don't injure the baby and then delicately extract these babies. And there is, of course, swiftness has to be there alongside gentleness. The reason I put in this case is we have to be always on guard, as I believe every C-section is unique and special. And therefore, all of us must be careful. Now, I'll ask Vijitra. We have not heard her voice at all. Where is Dr. Vijitra? Next question to Dr. Vijitra. Where is
Girija, before
I'm
going
here.
to that, I would like to say that instead of inverted T-shape incision, I think a J-shape incision will be better because very often I have seen that previous notes, the T-shaped incision would not have been given properly or the patient would have lost the discharge summary. So when we take her for the next thing, maybe probably with the T-shape incision, we have to plan surgery earlier, or if you are going to give for a VBAC, then we will land up in soup. So I think it is better we don't insist upon going in for a T-shaped incision instead of even a unilateral or even sometimes bilateral J-shaped incision will be of use.
I'm very lucky that in my life I never created any of these incisions and could deliver babies. So I think your technique and this preemptive planning, which comes with so many, your best learning people are your colleagues or your youngsters. Your students teach you a lot of things. And then you learn with their mistakes how not to do things. And that's how probably, yes.
Madam, one comment on the incisions in Madam is talking about it now. In premature sections, there is described a vertical lower segment section.
Chronos
There's
incision.
incision.
It's called as the
And
chronos.
I have tried it and it really works good. So you
Yes.
are not worried about extending it. It can
Laterally.
little bit even extension. There is no damage to the lateral tissues.
Oh.
Because in a premature baby, the lower pole is almost like a non-pregnant uterus. It's
Yes,
so small,
yes.
you don't know where to take the lower segment incision. So a
But
vertical incision really works.
Absolutely, because people have decapitated the uterus, very small premature babies. It went straight back and then.
Oh God. Oh God.
I have had an instance where a premature baby in an infertility patient, IVF ART done, was being done. She took an incision on the lower segment. She could not find the baby, so she went up and took one more incision.
Oh my God.
Oh my God. So proper planning, and therefore our panel is very important that we are sitting here and discussing. We feel C-sections are simple, but they are not. So Vijitra, are
Not
you
at all.
ready?
Not at all.
Vijitra, where is Dr. Vijitra?
Yeah, she
Yes,
is
sir.
there. Vichitra
Yes,
is there.
Okay. So Vijitra, this is Veena, who is a primary gravida with GHT, that is gestation hypertension, diagnosed at 28 weeks and GDM detected at 32 weeks, at 37 weeks in the ICU. For severe COVID infection, now on ventilator day 6, high D-dimers, fetal vigilance with NST daily and handheld Doppler, 2,900 grams baby and reactive NST. Mother has developed multi-organ failure and the decision of crash C-section has been taken. What are the prerequisites of a crash cesarean section? Vijitra, have you done any, Vijitra?
Ma'am, I'm here, ma'am.
Huh?
Have you done?
No, ma'am. I have not done.
Have you seen any?
Actually, no, ma'am.
Have you heard any?
Yeah,
Yes,
heard. Yes,
Do you
heard.
have a protocol in your place, in your facility? We need to have all our facilities where mothers are delivering babies should have a protocol, an algorithm for crash C-sections. But I am sure you are aware of the indication, so please answer.
So, for the perimortem C-section, is it the same?
Yeah.
Yes, ma'am.
So we have to press the right button. Usko bolna hai perimortem C-section, then she'll give the answer. Okay. Yeah.
But vitals are not mentioned here, so I thought
Don't bother about the maternal vitals.
Yeah, tell me. Yes?
Please unmute yourself, madam. Please unmute yourself.
Vichitra, unmute.
yes, ma'am.
Okay.
So incision to deliver interval should be less than 5 minutes, ma'am. So we prefer classical incision in that case. And first aim is to, as far as possible, save the baby and mother. At least if it is also not there, then we have our if even if it is preterm, then we have to deliver the baby so that we can avoid the hypotension for the mother.
Okay. Any reasons? What are the reasons for which we are doing this C-section? Anybody? Anita? Anita also has not spoken yet. Where is Anita?
Cord prolapse.
Okay.
Cord prolapse, ruptured uterus.
She is already on ventilator. So when we deliver the baby, hello?
Yes.
Hello?
The decision to delivery interval must be very short, madam.
Oh, yeah. Then?
Agreed.
So many times when we have very sick mothers and the situations that we discussed just now, or which we are giving it as a resuscitation for the mother and revival of the baby, we may consider doing this particular thing. And there are challenges that we see, that there can be breast enlargement and laryngeal edema, reduced esophageal tone, difficulty in intubation, high risk of aspiration, securing airway, etc. Aortocaval compression reduces venous return, and all these hemodynamics we must be aware of. It's always smarter to give her a left lateral tilt for that, so that there'll be some improvisation of circulation, not only to the placenta, but also to the mother. And we have to be looking for all the other background morbidities such as dilutional anemia. And you saw that this patient was very, very sick. So left uterine displacement, even while you're doing a C-section, does help. And I know that we have many senior anesthetists here, even in Cloud9 and in Bharti where I operate. They will quickly give a tilt, that tilt helps tremendously, especially if you have given a regional anesthesia, but in crash C-sections, usually we'll be giving a general anesthesia. Sometimes they are already intubated, so we are just doing the section. And it's important that we are, see, basically for resuscitation of the mother, her uterus has to be empty. That has to be the aim. So it has to come quickly out. Otherwise, you may not be able to give a quick and adequate resuscitation. So we all know that perimortem C-section is usually done for a patient who has a compromised health and may die. And maybe the C-section is not going to help her live either, but it may aid resuscitation. And it is usually initiated within 4 minutes of cardiac arrest. And that is what is very important. And usually the threshold of doing this is only after 24 weeks of gestation. And that is the guideline. So I was telling you to make a protocol. Recently, we made it in Bharti. It was a huge headache to make all that, because where to do section, what is going to be in your drum, what is going to be in your trolley, who are going to be the stakeholders, all these things have to be decided. And typically, as she rightly said, we'll be taking a vertical incision in this particular patients, and that will and relieve her as early as possible. Now, in the surgical approach, because that is where, as she said, vertical incision and taking out the baby quickly, and we require to have 2 teams who will be taking care of the mother as well as the baby. And that is very important. And then after the baby is handed over, the neonatologist will look after the rest of the thing. And very important, therefore, in here is a 4-minute rule, which is critical. PMCS is not just for fetal rescue, it improves maternal survival. Decision must be immediate, and we require a team coordination. Now coming to Dr. Saili. Saili is there? Saili Jagirdaar?
Yes, ma'am.
Okay.
Yes,
So we have Seema now in labor, 39 weeks with GDM and GHT, admitted in spontaneous labor. Progress to active phase and at 6 centimeters ARM was done, which revealed thick MSL. Emergency C-section was taken. Baby of 3,500 grams delivered swiftly. Placenta was delivered. The pelvis was filling up with blood, and the incision margins were caught with Alice forceps to reveal the active spurter on the left side, which was held with a green Armitage forceps, and the right side showed a hematoma increasing beyond the angle of the incision. And the edge was held with Alice's. What next? How to tackle this? Would this have been prevented? तो prevention तो हमने अभी discuss ही करा है. ये सब preventive करके भी ये सब काशीफल भोपड़ा हो गया. अभी बोलो. Saili.
The uterines have been ruptured on that side, or there was laceration and extension of the incision.
Yeah.
So the uterines have already ruptured. So the first thing that you do is you take the uterus, exteriorize the uterus out of the incision.
Okay.
So holding the uterus, taking the uterus out and angulating it is going to kink the uterine arteries and at least reduce some amount of blood loss.
Okay.
The second thing is you hold the angles of the uterus. You already held right angle with the Armitage. So the first thing is you ligate the uterine artery of that side.
Put a clamp first.
Yes, clamp and ligate the uterine arteries.
Okay.
And all the needles which are there on the incision, you hold them with Alice and start suturing the uterus.
Okay.
But if you think it's a broad ligament hematoma, which is not going to resolve with your uterine artery ligation, you will directly go for internal iliac artery ligation.
Yeah. So you can go for the internal iliac ligation. And how will be the approach for the internal iliac?
Approach will be from the posterior side.
Yeah, because here now your context
So you
is now
flip
the
the
posterior
uterus.
side. Just look for the course of urine.
Because of the broad ligament hematoma, you won't be able to approach it from the lateral aspect.
Correct.
Because all hematoma is already there. So you
And
flex
while
the
you are
uterus over the
exercising the uterus, one thing which I tell
Yes.
my students is you put your fingers on the uterosacral ligament. So if you elevate the uterosacral ligament, you will see the uterine undervision. And it will also be, the pulse pressure of the uterine will reduce. And you will be able to take the suture without fear of any bowel or ureteric injury. So that's one simple step of lifting up the uterosacrals will lift up the angle posteriorly so that you are able to see the things if you are lucky enough. But if there is a hematoma, you may not be so lucky. So I can see many seniors and many experienced obstetricians here. What would be your guidance? Anybody wants to give in any additional inputs for this particular, because this is something which is happening quite commonly nowadays.
Yes.
One, because big babies. Two, because techniques of youngsters are still sometimes, they have to understand how to deliver with proper flexion and then taking the baby out. So can you give us any more inputs? Sujata, madam.
Yeah, see, before going for internal iliac, I would deliver the uterus or exteriorize what you say. And because the hematoma is on the right side, I would put my finger below as what you said, uterosacral, feel for the uterine vessel. And even if the hematoma is there, I would still try and take one suture on that, because it's very easy to say internal iliac, but it's not all that easy. You would at least try and ligate the uterine vessel on that side. So I would take an incision, take a stitch on that side, maybe a figure of 8, wait for some time to see whether the hematoma is increasing or no. If not, then I'll start suturing and still wait for some time. Generally, 99% the hematoma will not increase because you have already taken the uterine vessel and everything is taken care of, rather than going in for internal iliac so early, So I would still wait for some time and see. And 99% it would be taken care of. If I still feel no, hematoma is still increasing, this and that, then maybe I would think. But initially and generally, this will be taken care of whenever you take uterine vessel. Only thing, as what she said, deliver the uterus outside, keep the hand below it so that there are hardly any chances of damaging the ureter or anything. You will take only the uterine vessel because you have lifted it up from the uterosacral and taken a stitch. So shouldn't be a problem according to me.
So many times we see some videos which are showing that uterine artery nicely anteriorly and posteriorly. Here, as madam said, just go through the substance of the cervix through and tie.
Correct. And
Yeah,
take figure
yeah,
of 8
what I do
suture and
is,
just wait. Yes.
yeah. What I do is, I just put in a clamp below this. Okay, below the hematoma, I put in a clamp. Then wait.
that
Then
it doesn't increase.
in the upper segment also, you put in a clamp. Wait for some time. Give good pressure. Invariably, that will stop. Then you can slowly suture the like a tire sutures. You can suture the along with the clamp. That will reduce definitely. And again, you see. Then after that, you see in the posterior aspect. And suppose if you are able to see the uterine, then you can tie it. So most often when you are doing the ligation of this hematoma below this area, it will include the uterine artery.
For that, you have to be extremely sure that your bladder has gone down.
Yeah, that is there, of course.
Very. So no compromise in any step, so
Yes.
that you can confidently put that clamp without knowing that you've caught the ureter. And one more modification, madam, nowadays we are having access to the Stratafix suture of Johnson & Johnson. So what you can do is, see here, what happens is you are putting the vicryl stitch, then you are making a loop and then you are tying. So here what you do is you just drive the needle, like you drive it in this plane, and when you come up, you just go right angle to that and pull it out. Immediately stop, no knots.
Yes.
So that also can be considered. So you can keep it handy so that you are able to take care of that. Now quickly, because we just have 9:30, it's already on the clock. So we have to finish quickly the next few things. Sharp dissection. Now there is a bladder injury. How can we prevent bladder injuries? Because we are doing a lot of previous C-sections nowadays. So many endometriosis operated cases. So many issues we are facing nowadays when we are in our practices. So how should you prevent a bladder injury?
High peritoneal opening, first thing. And if the bladder is very adherent, just do sharp dissection, but scissor pointing towards the uterus to avoid it. And if you are expecting any adhesions like previous to cesarean or any ruptured appendix like this surgery, you can keep also surgeon or urosurgeon standby also.
Or maybe just take an incision a little higher up and don't venture.
Higher up
Yeah.
incision. Yes.
And always put in the Foley's bulb. Put in a catheter. That will guide
Sometimes
you.
you may not be so lucky, and here is a 28-year-old bladder flap hematoma, presented with pelvic pain shortly after undergoing C-section. And you can see here a sagittal reformated contrast NRCT image. And you can also see the skin staples in the phalansteal incision on the arrowhead here. So you can see there's a hematoma here on the anterior uterovaginal fold. What will you do? She is gone home, suture removal. Abhi staples remove karne ke aayi, lekin pain. And you find that there is a hematoma. So this is not during C-section, but after C-section.
Yeah. What is size of the hematoma, madam?
ये क्या दिख रहा है ना? ये देख यहाँ से यहाँ तक इतना बड़ा.
Okay. Ma'am, personally, if I can say that if it is an asymptomatic hematoma, if with mild symptoms, she is not in a sepsis, then we can allow it to resolve, give her anti-inflammatory, good antibiotic. If required, admit for IV antibiotic. But however, if there are any signs and symptoms that the hematoma is increasing or is infected, then maybe we will have to go in for a surgery. At this point of time, laparoscopic surgery would be a good option.
Urologist.
We have done uterine artery embolization for 2 patients.
Yes, that also can be done.
That was a good
It can also be done.
But so I also
But it is
personally feel like
expensive.
yeah, like Supriya,
75,000 rupees.
Madam, expensive and not available at all centers.
All places, yeah.
Ah.
So most
in
of
our
the
town,
time,
we don't have
So
uterine
available
artery
everywhere is a
embolization.
gynecologist. So you can just do laparoscopic uterine artery ligation or an internal iliac ligation and drain it.
Yeah.
Or
see,
open
majority
it.
of the times
Role for
these,
conservative,
yeah,
role for
majority of the
conservative
times the
therapy
hematomas
treatment, we
will
should
get
always keep
absorbed
in
on
mind.
its own. They will get absorbed.
Yeah. So conservative treatment should be also kept in mind. It should be one of the first options.
Yeah. Yeah. And
Often,
it takes a
madam,
little.
when let me say this, when we are the primary surgeon now, we get all agitated and we want it to get over fast, and sometimes we make the rash decision of a second surgery. But so many times we all must have experienced that with conservative treatment, these patients, they do go on well. They just slowly the hematoma goes on in decreasing in size. Of course, we need to counsel the patient very well that it is going to take time because they expect you to do sonography every third day and the hematoma should disappear, which is not going to happen. It may take 2 to 6 weeks. If we counsel them well, monitor them well, many a time conservative treatment works.
But you have to
I'm
be
sure Ramani
patient
madam will
because
comment on that.
Agreed.
it will take
And
6
especially
months.
now when we put these patients on heparin, I find at least one patient every 3 months, she will have a hematoma that we have to accept. Because if we are not going to give low molecular weight heparin, the problem of pulmonary embolism, which is life-threatening, will happen. Recently, I had a patient, but she subsided. Just the next day itself, we identified, and then it was a volume we could calculate, and it subsided on its own. We need not worry. We just keep monitoring. That's all. And also monitor the vital signs plus the hemoglobin. If hemoglobin is going to drop drastically, then definitely that hematoma is going to be of bigger size. Hence, that is a size, time where we need to intervene. Otherwise, if it is going to be stable, we can monitor.
Absolutely.
Madam, I have had one patient like that. She was a case of jaundice. She had jaundice before surgery. During surgery, the parameters were normal. We gave her FFP. In spite of that, third, fourth day, she developed again jaundice and she had a pre-bladder hematoma. And she developed hematuria. And I had, after due consideration and consulting few seniors, I have advised them to do it conservatively. They were doctor family. They took discharge and they went all over the town finding if anybody will do surgery for them. Luckily, everybody supported that. If Dr. Supriya said conservative, please wait. And she just subsided within 2 weeks. The hematoma was totally gone.
Yes, agreed.
Nice.
Absolutely. So I think so I think we have come to the end. You must have seen purposefully not taken placenta.
Girija, one thing is, for previous C-section, we now come across dense additions in the anterior abdominal wall. So people should also know how to go in for a extraperitoneal C-section. They'll be digging right into the uterine anterior wall. So the youngster should be also thought about extraperitoneal C-section where it will be easy.
And here also the principle of lateral window works.
Yes, that the lateral window we have to go through.
Yes. So I think we will come to a conclusion now, and we have not taken morbidly adherent placentas and placental issues, as you must have seen, because I thought that they are totally a different ballgame in C-section technical difficulties. And there has been this publication, a systematic review in 2016, which talked about techniques for assisting difficult delivery at C-section. And it concluded that there is currently insufficient information available from randomized trials to support or refute the routine or selective use of tocolytics or instruments to facilitate infant birth at the time of difficult C-sections. And there's limited evidence that reverse breech extraction may improve maternal fetal outcomes, though there was no difference in primary outcome of infant birth trauma. Further randomized studies are needed, so all of us can come together. There are many youngsters here. हम तो थक गए research करके. You can all help us and bring us smarter tomorrow with AI and everything. Thank you so much. I think we can have a round of applause for ourselves. And I hope we all enjoyed the panel.
Yes.
Thank you, madam.
Thank you so much, and a big round of applause for Girija ma'am. Girija ma'am for being such an excellent moderator, madam. Wonderfully done.
Thank you. Thank you.
And gratitude and namaste to Ramani ma'am for being there as our mentor in this panel. Thank you so much.
Thank you.
Thank you, Sampath ma'am, for an excellent
And best
session.
wishes to
Really
Sampath.
well curated topic. Thank you so much.
Yes.
Very
Yes,
nice
thank you so much.
practical discussion, Girija. Very nice.
Thank you,
Yes,
madam. It means a lot when you are appreciating, madam.
That's
And I
the
hope
reason
all
we
the
are calling.
young feet here enjoyed. I hope.
So young to senior, all enjoyed Girija.
Thank you.
Thank you, madam.
Okay.
Thank you, madam.
Thank you, madam.
Thank you. Thank you, madam.
And finally, never
you,
forget
madam.
to support Sampath so that she
Yes,
wins
ma'am.
and she is
Most
going to be
important.
our future
Sure,
president.
sure,
So
sure.
we need support from all the AMOGS people.
Yes.
Yeah. Definitely.
Throughout India.
Thank you. Throughout India. Of course,
Bye.
today we are meeting the AMOGS people.
Thank you. Thank you. Thank you. Thank you
Thank
for
you, ma'am, and
the
bye-bye. Good
wonderful
night,
panel.
everybody.
Bye.
Bye-bye.
Bye. Good
Girija.
night. Good night.
We will have the formal vote of thanks. See, I thank Dr. Ameya and Dr. Rohan for having with TNFOG continuously for 3 weeks. We had the wonderful topics for 3 weeks. And I thank Dr. Ajay Mane and Parag for being the chief guest, and Revati Madam and Vidya Prabhakar for being the guest of honor. And we had a wonderful talk by Dr. Gaurav Desai. I had this talk in Amaravati. It was entirely different PPH, and I told him you are going to give the same topic in the TNFOG and AMOGS. Otherwise, it was emotive bundle. But it was wonderful, Gaurav, and I thank yes, Dr. Chitra and Dr. Subhashni for sharing, and Dr. Girija. Dr. Girija is always obstetric topics. She is fantastic in moderating. I thought today she has she was having another one panel in 27. Morning, I sent her the link. Immediately, she made it that she will be here. Thank you, Dr. Girija, for the wonderful moderation, and Dr. Ramani for Madam for the expert. And as a panelist, Dr. Sujata Dalvi Madam, from the senior to all Dr. Supriya, Dr. Manisha, Dr. Vijitra, and Dr. Madhumati, Dr. Sudha, Dr. Prema, Dr. Who I think Sheetal and Shalvi, Sayali, all had the good interactions. Thank you so much, and Pradnya and Dr. Madhumita for the wonderful MOC, and Dr. Sagiti from Shield. I thank all the delegates for being here, and I think everyone would have taken a wonderful take-home messages. Thank you once again. I request all of you to vote for me. I am contesting for Foxy President. The voting date is August 1 to 10. Please vote for me. Thank you.
Yes, ma'am. Sure.
Okay.
Thank you.
Good
Thank
night.
you.
And best
Good
wishes.
night. Good night. Good night, Sujata Madam. Good night.
Good night, ma'am. Good night, ma'am.
இல்ல ஒண்ணும் பிரச்சனை
Thank you, madam.